Hello, my name's Alistair McCall, and I'm hosting the latest in the series of Health Tech World Roundtables discussions. And today we're focusing on weight loss management, and particularly weight loss management with reference to long-term solutions and long-term approaches. I'm delighted on behalf of Health Tech World today to welcome our panelists, who I'm really pleased to say have agreed to share with us their experience and their insight and some of those new approaches that are being developed with reference to weight loss management. So we're going to kick off our discussion today by asking each of our panelists just to say a few words about themselves, their organizations, and their particular areas of interest. So if I could come firstly to you, Martin, please, to introduce yourself.
Thank you, Alistair. Good morning, all of you. My name is Martin Carlsson, and thank you for having me here with you today. I'm the Chief Medical Officer and co-founder of Yazen Health. It's a digital healthcare provider for medical weight loss. So that is what we are talking about today. I'm from Sweden. I'm specialized in endocrinology, internal medicine, and clinical chemistry. And in my career, I've devoted a lot of time to clinical work and also research on chronic diseases, common chronic diseases like high blood pressure, type 2 diabetes, and obesity. I'm also currently an associate professor at Linnaeus University in Sweden, where I specialize in endocrinology and telemedicine and so-called big data research. And most recently, I co-founded this digital health service called Yazen Health. This is why I'm here today with you. Yazen Health focuses specifically on obesity treatment. And effective treatment of obesity, that is what we will discuss together today. Obesity treatment that not only provides weight loss, but also better health and weight stability after weight loss. And this is typically multidisciplinary. I want to emphasize on that. So we at Yazen, we integrate modern effective weight loss medications with expert lifestyle guidance from a team of doctors, dietitians, psychologists, and personal trainers. And this goes via our own app that the patient also have and our own digital platform. And this approach using a team together with these modern obesity medications that now are available is proven to be very effective actually for achieving effective and sustainable weight loss. And I'm personally convinced that digital solutions in healthcare like ours at Yazen Health are an effective way to also empower patients. That is to help them to get tools for better health themselves. So that is the vision that drives my work as a clinician, researcher, and entrepreneur, to use science together with modern technology to create meaningful change in how we monitor, maintain, and improve health, especially in chronic diseases such as obesity. Thank you for this opportunity to introduce myself.
Thank you very much, Martin. If I could come to you next, Neel.
Yeah, thank you, Alistair. And yeah, morning, guys. So I'm Neel Gupta. I'm medical lead at Oviva. Not dissimilar to what Martin was outlining, Oviva provide digital healthcare services for people living with weight-related conditions, so primarily obesity and type 2 diabetes. What makes us slightly different, I think, certainly in the UK, is in the UK, all of our services are provided through the NHS. So for the patients, they're provided for free. We don't have a direct consumer self-pay offer. And so as a result, we have a real focus on the choice that we offer and the personalization and making sure that our services are accessible to all, regardless of background, socioeconomic background, ethnic background, etc. And we provide a range of services that vary in intensity. So that at one end of the spectrum, there's a fairly low intensity, 12-week behavior change led weight loss program. And at the other end of the spectrum, we provide a 2-year medically led program, not dissimilar to what Martin was outlining, with a full multidisciplinary team, doctors, specialist nurses, dietitians, psychologists, alongside prescription and monitoring of the new weight loss medications, which I'm sure we'll come on to talk about. So there is that range in terms of the intensity of the services that we offer, all through a digitally enabled model. And a bit about me and my background. So I'm a GP by background. I've been a GP in London for a long time. And alongside now being a provider of weight loss services, I've spent a lot of time, well over a decade, as an NHS commissioner. So on the other side of the table, on the payer side of the table. And it gives me multiple different perspectives on a lot of these challenges. And as a result of that, I have quite a strong interest in population health, value in healthcare, and also how we address health inequalities.
Great. Thank you very much for that, Neel. And last but not least, Simon.
Hi, everybody. My name is Simon Pickup. I'm head of health at Sweatcoin. So I basically run the health division outside of the direct-to-consumer freemium model that we have. My background, too many years in healthcare, straight from graduation. I worked for a number of years in pharmaceutical, in sales and marketing, and in the digital world, and more latterly in the behavioral change space. So a little bit like Dr. Neel. I worked at Lever Healthcare. I ran the UK, and we were one of the first national diabetes prevention providers, along with Oviva. Besides working with the likes of Noom, as I mentioned, I'm now part of Sweatcoin. And Sweatcoin, just a little bit of an intro. Believe it or not, it's the #1 health and wellness app in the world. It's actually #1 in 65 countries. We have 150 million plus users globally, more downloads than WhatsApp over the last 2 years. And we have about 10 million active per month. So we have a very active universe. We too are very much I suppose geared to those that are really difficult to motivate, are really difficult to engage. So the model of rewarding movement the way we do, when we work with 600 brands plus globally to provide us with free product, which enables us to offer our rewards to our users. And really from the spin-off of that and the success of being able to motivate people is putting that to good use in the directly in the clinical healthcare world. So together with Southwest London ICB, we co-created, I suppose you could call it a challenge brand to the National Diabetes Prevention Programme. We call it the Prevention Decathlon, simply because it's 10 weeks in duration. So it's nice, short and sweet. And the idea is that those users that may decline the offer of the National Diabetes Prevention Programme or fall out of the National Diabetes Prevention Programme, they might want to take up the Prevention Decathlon. And we have some phenomenal stats from pilots we're running around the UK, where we can demonstrate a 90+% completion rate. Out of those completion rate, we have about 75% actually from the low socioeconomic and BAME communities as well. So it's really hitting hard those that really need the help. Similar to the NDPP, we have an average of 3 kilogram weight loss, which is phenomenal stats as we look to expand the offering wider across the NHS. But also we're getting a lot of interest direct from the business community as well, in terms of providing partnership programs with health insurance, pharmaceutical and private health.
Great, thanks very much for that, Simon. We're going to spend most of this discussion talking about new approaches and innovation and looking towards the future. But before we do that, I'd just like to go through where we are at the moment and ask each of the panelists to say a little bit about the obesity epidemic that we hear so much about, its wider impact on health, and what the big challenges are really, and then we'll come on to talk about some of those new approaches and innovations. So maybe Martin, you could kick off again, and we'll go around the panelists and just get a bit of a state of the nation in terms of where we are now and what the big issues are.
Thank you, Alistair, and interesting to hear about Oviva and also Sweetcoin about gamification and nudging. It's really important, I think, and using digital tools for activating patients. But talking about obesity and the so-called obesity epidemic, it's really a huge, big global problem, not only in UK and Sweden, it's a global problem now. I think it's one of the biggest health problems of our time. And also in children, obesity has increased dramatically in recent years and will continue to increase if we are doing nothing more. And the consequences of this epidemic are enormous, in addition to all human suffering with limited mobility and a lot of guilt and shame. There's a higher risk of many, many other diseases, such as what we talked about earlier, type 2 diabetes, cardiovascular disease, infertility, multiple forms of cancers, actually, fatty liver disease, sleep apnea, and chronic pain, and also mental health issues. So what we need to do is to treat obesity, which is the root cause of many of these diseases. If we can treat obesity effectively, we can get rid of many other chronic diseases. And I think not only healthcare, but also the whole of society needs to be involved to do something about this situation. It's not just a matter for healthcare. So we need to talk about modern foods, ultra-processed and hyper-palatable foods. These foods are major contributors to obesity, and they are stimulating the brain's reward centers and leading to overconsumption of food and obesity. And this will trigger patients who are genetically predisposed to have obesity, and they will have disorders in appetite control, and this will make some individuals more susceptible to these environmental factors. So I think that obesity, it's also requires personalized treatment approaches, and this because one size does not fit all. So we need to have different approaches, different ways to manage lifestyle, and also different kinds of drugs.
Thanks, Martin. Neel, clearly a global and societal issue. Maybe you could say something about your perspective and also touch on the impact on the NHS, which you're clearly working within and working alongside.
Yeah, sure. Thank you, Alistair. And I'll try and avoid repeating what Martin said, because clearly I agree with everything that Martin has said there. I suppose, I end up talking about obesity a lot to various different audiences. And I think the thing that I always come back to is attitudes. Okay, so as Martin has outlined, obesity clearly is not a lifestyle choice. It is a complex chronic condition that can affect pretty much every system in the body. But, not everyone is convinced yet of that. And I mean amongst senior decision makers, politicians, the clinical community. So there's still some way to go on that. I think the next step when people come to that conclusion is you often hear well-intentioned people say, well, with obesity, it's all about prevention. That's partly true. Prevention is important. But in the UK, we have 25% of the population living with obesity, 3 to 4% living with complex obesity. The time for prevention alone has long gone. And we need prevention and treatment at the same time. At the moment, we're doing neither particularly well. And I think in both spaces, there is so much scope for innovation. Our traditional models, if you think on the treatment side, our traditional clinic-based model, come in periodically, see a healthcare professional, the doctor will see you now. It's just not fit for purpose for the scale of the challenge. out there. So there's so much scope for innovation there, but we do need to bring people with us and, think about those attitudes that are there. The NHS is, I would agree, it's one of the single biggest problems facing the NHS. You just look at the statistics, 25% of the population, the cost of the NHS, £19 billion per year. Hospital admissions related to obesity going through the roof. There's a figure of up to 200 different conditions are related to obesity. The common ones are the ones we all know about. Type 2 diabetes. We're seeing an explosion in this country of people under 40 living with type 2 diabetes linked to the obesity epidemic. And that form of type 2 diabetes is particularly aggressive and particularly destructive. So it's everywhere you look. And I think some of those things may be very familiar. I think the things that maybe aren't as familiar are the links with cancer. So it's pretty much the second biggest modifiable risk factor for cancer behind smoking. And as we see, that's common cancers like breast cancer and bowel cancer. So there's a huge amount going on there in terms of the impact on the individual, impact on the health service. And I think what we're also seeing, and I think I'm pleased that we're recognizing more and more, is there's a knock-on impact on society in terms of economically. So in the UK, we have this statistic around the number of people who are of working age who are economically inactive at the moment, and everyone's sort of scratching their head and trying to work out what's going on there. I've no doubt obesity is playing a very significant role in that, given the number of conditions that are linked to obesity. And we have in the NHS 7 million plus people on a hospital waiting list for procedures and interventions. Again, obesity will be driving a lot of that need, with the same people living with obesity needing multiple specialties and multiple medical interventions. So, the case, I think, is as clear as day, but I think there are still some attitudes that need to be addressed before we can start to meaningfully tackle those challenges.
Yeah, I'm sure we'll come back to that sort of theme of education as well, Neil, and whether or not globally governments and legislators are really committed to doing what's necessary to tackle the scale of the issue that you talked about. Simon, your thoughts on the scale of the issue, and you mentioned earlier some particular communities, maybe prosperity or the lack of it, where the issue is particularly acute. It'd be quite interesting if you could dig into that a bit more as well.
Yeah, thanks, Alistair. Listen, I agree with both Martin and Neil. Hit the nail on the head there. I mean, we have a global issue, ever more present here in the UK. What is very interesting, though, if you look at wider Europe, Spain and Italy have the lowest percentage of the population that are obese. Now, you look at their lifestyle versus our own lifestyle in terms of the way they eat, the way they consume alcohol. There's a distinct difference. We all experience it when we go to sunnier climes around Europe, of the way they live. Just simple things about the way we consume alcohol. We tend to consume it on its own, maybe with some salty snacks, because we all get a bit peckish when we're having a little bit of a drink. But in Italy and Spain, predominantly, they're drinking alcohol only when they consume food. And they're doing that in a very sociable way as well. So I think that attitudinal piece that Neil picked up is really important. And, in terms of the programs that, we all provide, they're all very important. And it's that behavioral change aspect that we've really got to drill into the population. And as Neil mentioned, starting at a very young age, how we educate kids when they're in school, and also how the parents are living with them, bringing up in the family home. Even if we could adopt just some of the small behaviors of Southern Europe, I think that will be quite impactful. And there's no doubt about it, the GLP-1 medications are phenomenal. And, the course that Oviva are providing over those 2-year periods, making a real difference. What is important, obviously, during that time is that those new behaviors are embedded. There's no doubt about it, the GLP-1 it's a magic drug, but at the same time, there's no point unless people have dramatically changed their behaviors. So in terms of moving more and looking at what they eat and when they eat those types of food and drink. in terms of our own experience and looking at the populations that we serve, Sweatcoin is almost the opposite end of Strava. So we are really motivating those that are really tricky and difficult to reach. I think the success of our program, and in terms of who is coming on the course and completing the course, is that it is something for nothing. So in other words, those rewards are really motivating people to go onto the course and complete the course. So it's very much educating them, but also when we quiz and we gamify the experience, we're rewarding them still further, and we're rewarding them with healthy products as well. So we're not talking about the Starbucks mocha latte, for example, if there is such a thing, by the way, but we're rewarding them with, the good old humble Tesco voucher, for example, and we encourage them to, take a picture of their basket, go home, show us how they're cooking, and we also encourage them to form a social group outside of our app as well. And so to share, for example, cooking tips, to meet up on walking expeditions, and really sort of trying to make people part of a community, like-minded souls. And therefore, when they finish the program, hopefully they keep on staying motivated. Now, interestingly, even though our program is only 10 weeks in duration, since I've come into the organization, I realized that behavioral change can be shorter or longer depending on the individual. And so post 10 weeks, we actually have a further 12-week check-in. So once they've finished their hybrid experience of in a classroom together with a digital app, we provide the digital-only experience for a further 12 weeks. And the reason for that is that we don't provide them with any new content, but we keep on reminding them of the content, keep quizzing them, keep gamifying the experience, but most importantly, rewarding them for their knowledge and also to keep up their steps. So we have things like streaks, we have things like an AI walking coach, and ideally at the end of 12 weeks, of the further 12 weeks, should I say, so 22 weeks in total, is to see a maintaining of their behavior. And in fact, our second program, which is our prevention of CVD, so we have two programs for type 2 diabetes, one for CVD, we're seeing a continued increase of average steps. So it starts off about 4,000 steps a day, the end of 10 weeks, 5,000 steps a day, and at the end of 22 weeks, goes up to 6,000 steps a day on average. Now, obviously, these are people that have traditionally not moved a lot, are really difficult to change those behaviors. So we're seeing big success there.
Great, thanks, Simon. Martin.
Yes, thank you, Simon. It's interesting, I think, that you mentioned alcohol. I mean, it's a big. We know that many of our patients they tend to drink a little too much alcohol, maybe, which will increase their obesity and overweight. And one interesting thing about these new modern obesity drugs like GLP-1 is not only that you tend to be more less hungry, but also you tend to drink less alcohol. That is what our experience and many other experiences actually. And also some patients they smoke a little less. So there's something in the brain satiety and rewarding system that are affected with these new drugs. And I think that is very interesting, actually. And you also talked about these drinks. And I think one of the big problems is that all these drinks with added sugar that we have all over the world. And in some countries, actually, they have warning signs on these, like these drinks with added sugar. And they are discussing sugar tax. I'm not sure if you have discussed that in the UK, but that is being discussed more and more all over the world now, actually, for treating the obesity epidemic. So that's just a comment.
Thanks, Martin. It's interesting, before we talk about new approaches, I mean, I guess prompted by what you've said there, Martin, the food and drink lobby internationally is incredibly powerful. Are you starting to see a recognition amongst major food and drink producers that they have a significant role to play in this?
Absolutely. And I think they will need to react on these novel obesity drugs. There are many global companies all over the world who needs to react on the new, this paradigm shift that we now can treat obesity. And I think that, you see it in chains, physical fitness chains. They have providing GLP-1 programs, for example, and you will probably see among the big chains selling foods as well, that they need to adapt to this new situation with the modern obesity drugs, I think.
Can we sort of move on to talk about the new generation of weight management tools? A fairly wide spectrum, new approaches, innovation, the things that are happening now that promise significant change for the future. I don't want to go to any particular panelists. I'll just sort of open it up for anybody that wants to talk about specific weight management tools and new approaches. Simon.
Yeah, Alistair, it's a very interesting area, weight management. As we all know, we've all experienced the different models and techniques and programs that have come out. We, approach it, I suppose, slightly differently, where, we're looking at trying to educate users throughout a program, which is hybrid in nature. So I think we've never lost the success of the good old-fashioned Weight Watchers model, where people enjoy going to a classroom. People enjoy, I suppose, sharing stories, sharing their successes. I know in the old days they dreaded getting on the scales, but those are digital scales that were official rather than sort of testing at your own time at home. I've never lost that. So in terms of us creating our prevention decathlon, the very outset is that it's hybrid by nature. So we're getting communities that qualify together near their GP surgery, obviously encouraging them to walk there, and we're educating them in a 2-hour session once a week over those 10 weeks. So part of the course is that community. It's fun by nature, so it's not dreaded in any way. I know lots of programs where they might dread going to a particular session and therefore don't attend. It's trying to provide, a clinically relevant program that is fun. So it's about stretching. It's about practicing stretching. Simple techniques to get people warmed up, but also, ways of moving more, not just walking, even though obviously ours is very much geared to step movement, but getting on the bike, maybe going swimming, but very much doing it in groups, in families, doing it together, because it's, as we know, it's fun together. And the digital element of it is a very important integral part, obviously, because of it is it's motivating people to complete the program. But when they're not in the classroom, it's reminding them. So, for example, our AI walking coach, it's nudging them on those behaviors. It's monitoring their streaks. So it's not about doing it on one day. It's about doing it over 7 days or over a month. And it's actually rewarding them for doing those streaks. And we have the humble sweat coin, obviously. So every 1,000 steps, you earn 1 sweat coin. But on the prevention program, we also have our extra health rewards as well. So that combination is seeing a dramatic success factor, as I said, plus 90%. I know the National Diabetes Prevention Program is a lot longer. For example, it is obviously a 9-month program, and in the US, it is a 12-month program. And you've got to be really committed. And in fact, in the US, I know they throw more at them in terms of rewards to get them and keep them on the program. And with a humble NHS, we don't have such luxuries. And so it's a real difficulty keeping on that program.
Thanks, Simon. Martin, and then I'll come to Neel.
Thank you, Simon. It's interesting about communities when patients are helping each other, and we have community in our healthcare system as well, Yazen community. And we see that the patient really benefit from this, discussing problems with each other. And they go through our educational programs. And when they have gone through it, they can become a mentor for other patients as well. So I think it's very good actually to use other patients, and they want to do this because they have suffered so much from their obesity during all years, and they are so happy that they are now helped and they have lost weight and everything they can do. So they want to help other patients as well. So I mean, it's very important, I think, with this using other patients to help patients. I think also that, I mean, talking about new novel treatment models, I want to emphasize that I'm convinced that digital methods such as you use in Oviva and Sweatcoin and they are here to stay. And I mean, particularly they are well suited to address challenges of chronic diseases since like obesity. And also using a team together with this, with the lifestyle treatment. And we have seen and research show that this will provide significantly better weight loss than using only medicine. So I think that is very, very important with digital care, that you also can, it gives a good accessibility for the patient, and the doctor can customize the care for the patient, and it's more easy to monitor patient data and adjust treatment plans and really provide personalized guidance to patients, so they will gain a better health really with digital tools. So, and I think you need to combine methods like yours, Simon, using nudging and gamification with traditional tools. So.
Thanks, Martin. I think that's a really interesting point, that digital offers, access to people regardless of age or community or background, and it allows that personalization as well, and people taking responsibility for their own healthcare as well.
And you can have the team with you when you are on vacation or when you are home at the evening. You can have access to them everywhere. So that is really a benefit of digital care.
Yeah, exactly. Thanks, Martin. Neel, if I could come to you, please.
Yeah, I just wanted to pick up on what Simon was saying, because I think if you asked the average person about, what does a weight loss intervention, a weight loss program look like, probably a Weight Watchers group is the thing that might jump into their mind. And I'm deliberately not going straight to talk about the medications when we talk about innovation, because there's a lot more happening in this space beyond just the medications. Clearly, we prescribe the medications, but Oviva started primarily as a behavior change therapy company, and that's still the core of what we do. So I think it's useful to understand, well, what are the limitations of a traditional Weight Watchers Slimming World model? So people who go there often get quite good results, let's say, but it's, for me, one of the big questions is who's not there. Okay, so often those groups are very heavily weighted towards female participants. It's very hard to get men to go to a weight management in-person group in a community centre. And so what we see with digital is we get almost 50-50. We could even that out at a stroke by offering a digital and remote intervention. Often people in those groups are not from the more deprived communities. They're often not from minority ethnic groups. Again, what we see through digital and offering choice and, for example, the ability to deliver the intervention in different languages because it's remote, we start to even out some of the demographic characteristics of who's participating in this intervention. And so what we see is a much more even split when we've got a digitally delivered intervention compared to a more traditional in-person group. So if you think about the barriers that are there, if you put that often, as we do in the NHS, we're going to put that on a Tuesday afternoon. You've got to come to a community centre every fortnight. I mean, if you're working, if you've got shift work, childcare, other caring responsibilities, all this sort of stuff, transport costs, parking costs, there's so many barriers to that model that when you just look at the tip of the iceberg about what results they're getting, that's great, but we're not reaching the parts of the population that we need to reach. Actually, the people who are probably at higher risk of having those heart attack, type 2 diabetes, etc., are not there. And digital is a means that we can reach those people, and we can deliver the intervention in a way that fits in with their life, and we can get equivalent, if not better, outcomes through that, through the means that Martin and Simon have been talking about, that high frequency of contact, using the tools in our digital intervention, the gamification, the nudges, the goal setting, the tracking, all of that good stuff that's based on behavior change theory, but we can actually get it to the people who need it. So I think, we're still a way behind that in the NHS. We still focus very much on traditional care models. The hospital specialist weight management model is seen as the gold standard when it just isn't. The community group meeting regularly is seen as the best form of, but actually, I absolutely believe digital is superior. There are people for whom it won't work. We've got to recognise that not 100%, but in my mind, it's 90% of people. Digital should be the default mode of delivering, whether it's the lower intensity Weight Watchers equivalent weight management program or the higher intensity support around GLP-1 medication. Digital should be the default, and we should be delivering in a more traditional way by exception.
Thanks, Neil. Martin?
Yes, I mean, traditional models like Weight Watchers, they work, but after, when they lose weight, they gain weight again. I mean, that the typical JoJo dieting. So, I mean, that's why modern drugs are so effective, actually, that you maintain the weight loss. So it's important. It's interesting that you have so many men. We have the majority in Yazen are women, but actually obesity is a little more common in men than in women, and it's data also show that obesity is more dangerous in men than in women. So really, we should the medical community and the community should emphasize on finding more men to treat. I think it will lead to better health outcome if we could do that. But still, in community, it's more important for women. They are so stigmatized because of their obesity. It's not that much for men, actually. I think that's why women tend to seek advice more for their obesity than men.
Thanks, Martin. Simon?
Yeah, just carrying on that theme. So what we're finding, I mean, the people that are attracted to our program tend to be those that I suppose are maybe not necessarily in full-time employment, are unemployed. And therefore they might have more access. We do obviously have classrooms in the day as well as in the evening, and the whole purpose is that it's supposed to be very close to where they live. But there's no doubting that there are those that prefer a face-to-face element and those that prefer a digital-only element. I did find it quite interesting at the start of the digital availability on the National Diabetes Prevention Programme, where there was a limit of how many people could go on the digital programme, which made no sense to me at all. I'm probably with you there, Neil. It should have been open and you should have actually had access. What's interesting is that in our success of motivating those that are really difficult to reach, we're now also a national diabetes prevention provider, but a retention improver for one of the largest providers on the NDPP. But interestingly, that's on the face-to-face program. So people that have shunned digital, have gone on the face-to-face program, and we're offering them a digital service to try and improve their motivation to keep the course of the 9-month program. So if that's not a big hurdle, then I don't know what is, because of they've shunned away from digital, and we're seeing about 22% increase of retention for those that download the app. Now, obviously, people have gone on that course and they might not even have a smartphone, or have chosen not to go on the digital program. Interestingly, we are involved in other programs. So we're part of first ever program for type 2 diabetes, but in the young adult population. As you know, there isn't really such a program. It's sort of those that already have type 2 diabetes are shoehorned into one category. Now, with the younger adults, when I mean young adults, I mean 18 to 24. There is a particular challenge there to keep them on a particular course. And together with King's, Guy's, St. Thomas's, we've seen some phenomenal results of motivating these young people throughout a course. And we're seeing about a 33% increase in their movement. So on our prevention decathlon, we're seeing a 45% increase on their movement. And on the standard freemium, as I call it, Sweatcoin service, we're seeing an average of 20% movement once they start using the Sweatcoin. So you can see the different patterns with the different types of population. And incidentally, the average age of our prevention decathlon user is about 56. And we are seeing a split of the demographic. I think females slightly higher than the male, but we're only talking about 1 or 2%. It's quite spread.
Thanks, Simon. Martin?
Talking about face-to-face appointments, I think sometimes, of course, it's necessary to have that, and we have videos as well sometimes, but it's much more convenient for the patients often to have just chat communication, and you don't have to schedule it with the doctor, and you don't have to comb your hair and dress up, and you can actually lay in your bed and talk to the doctor or the dietitian, and that's very convenient. And also, when you have a face-to-face conversation, you often forget what has been said, or you can forget to ask something. And but if you have a chat communication, you can check back always on the messages and see what has been said. So it's less risk that you miss anything actually with the video, I think. With our patients, we have in average we have about 70% women, and they are in average 44 years, I think, and BMI 34. That means that in average they have it's women that weighs 100 kilos, and so they have about 25-30 kilos overweight. So, and they will often lose that during the first year or first 1.5 year actually. So that is our average patient.
Thanks, Martin. Neel, could you? I mean, we've touched on cultural attitudes and how important that they are, in the mix of things. But it strikes me that education sits right at the heart of this, with people understanding what good health looks like, what food to eat, the role that exercise plays, as part of this hybrid solution. Is education absolutely fundamental to this for individuals to really understand how they can change their behaviour?
Yeah, I think that's absolutely right. I mean, I think so much of this, certainly at the prevention side, rests at the policy level. So we've had, I don't know what it's like in Sweden, Martin, but we have this sort of knee-jerk reaction to anything that is around this area of people crying nanny state. If we want, but so education is absolutely key. But as well as creating and Simon, you talked about this, about some of this sort of the background and the cultural setup, creating the environment where it's easy to take physical activity as opposed to the default of avoiding that, where it's easier to make the right food choice as opposed to. So I think it's that message that obesity is not as simple as calories in versus calories out, that it's not as about being greedy, lazy, or both. That is not well understood, I would say, amongst the population. So I think there is a huge piece of education that is needed to get people up to date with what the latest science actually tells us about what's important around obesity and what you can do as an individual to reduce your risk of obesity, what the risks of it are, what you can do to treat obesity if you're already living with it, and then government to step in appropriately to put in place the environment where making the right choices to either prevent obesity or treat obesity is the easy thing to do. So I think we're quite a long way away from that. And certainly when I speak to politicians from time to time, many of them don't appreciate that. Hopefully, we have a new government, as every new government comes in and talks about the importance of prevention. And let's see in terms of whether they follow through with that. But I think it is really important to get that into schools as early as possible, because we are seeing by the time kids are in year 6, 11, there's significant rates of obesity, and that's growing. So yeah, absolutely.
Is there anywhere that you'd like to see much more innovation across all the areas that we talked about?
You mean in general terms?
Yeah, areas where you think more innovation is required to have an even greater impact?
Absolutely. I think that talking about obesity treatment, it's fantastic that we have these new drugs available and that we have telemedicine that really works. But we have some patients actually that do not respond. They do not respond on surgery, and they do not respond properly on medication. We call these patients non-responders. There are not so many, but they exist. And the more research must be done to really individualize and personalize treatment, because there are many reasons why you gain weight. You can be more hungry and then you eat more. That's the most common way. But you can also eat from emotional reasons or other reasons, and you have genetic reasons for becoming obese. And I think if you really need to treat everyone, more research must be done to really personalize and individualize treatment.
Thanks, Martin. Neel?
I just echo that. I think if you think about the future direction of travel, that sort of personalization for me is absolutely key. And I say this as someone, one of the reasons I'm so passionate about weight management is after many failed attempts, I lost about 5 years ago. I lost a significant amount of weight. I managed to find the right approach for me that was effective and sustainable, but that was through trial and error. And whether we're just talking about I'm being unfair on Weight Watchers, but the traditional Weight Watchers model is calorie deficit. Eat fewer calories than you expend. There are so much more in terms of dietary approaches, low carb approaches, intermittent fasting, whatever it is. You personalize that element of it. We'll get to a stage where we'll understand who's going to respond to the specific drugs better through understand, and we'll be able to tailor the medical intervention. And then really, as we've talked about a lot on this, what digital can do is to tailor the support around people's lives. So that's where you need a lot of personalization. People lead very different lives. They come from different cultural backgrounds, different socioeconomic backgrounds, and we can really personalize that element of support. So I think where this is going is that we give every single individual the greatest chance of success, not just in terms of losing the weight, but in terms of sustaining the weight loss, because that's what's really key. There's no point losing weight for a short period of time. It's only as valuable if you can keep that weight off.
Thanks, Neel. Simon?
Yeah, no, I agree. Listen, I think we're all very much on the same page. Prevention starts with the best possible education and the start in life, and that all starts with the 4 of us around the room being parents. I'm saying that, I'm presuming we're all parents. In terms of teaching our children the right ways to live in all spheres, and even something simple like the ability and the art to cook, and to cook proper food, fresh food. It's very easy in this rushed world when we've got too much on, or we've got to get back for the footy, for example, to sling something in the oven, but it's, you know, high in salt, high in fat. But actually go back to the tradition of cooking. And that's part of the prevention. So, you know, should we or could we be doing more at schools? So when we have the good old fashioned dinner lady, you know, is there some combination between what the kids are eating and what they're learning in terms of the food that's presented in front of them? And actually, can they be the ones that go home and say, hey, mum, you know, dad, why don't we cook? Or, you know, why don't we, you know, all get around the table and cook something fresh? I know that's quite an idealistic world, and I know in this today world that, you know, fast food is cheaper than fresh food, sadly. And maybe there's something that we need to do there, is to make sure that fresh food is cheaper, more accessible, without harming, you know, the producers. And I think, you know, that prevention piece starts right there, and actually encouraging people along the way to actually go out and expend what they're eating in terms of, you know, greater movement, get more involved into sport, or, you know, the simple thing of walking the dog more, or just going out for a sort of a family walk around the park. Getting people to see those results, and you can see those results in, you know, less than 2 weeks. I myself, you know, I have a penchant for crisps, which are terribly bad for you, you know, consuming 250, 300 calories a pack for nothing. And, you know, they don't fill you up. But, you know, when I go through spates of not eating crisps, which interestingly is linked to alcohol consumption, I do see a dramatic effect. And this is someone who walks a lot, because I have a dog, play tennis a lot. It's a real passion of mine. So I do keep fit and healthy, and I love cooking. But, you know, we all have our little secret penchants, and mine is crisp. Well, actually, it's chocolate as well. But yeah, prevention is the key. And, you know, one service does not fit all, that's for sure. And I think coming at it from different angles with different types of services, and we're all in the digital game, and digital definitely has a huge part now and going forward, and with new technologies coming out which are more accessible. So we're seeing more of these health rings. Samsung have just released theirs, and we're going to see those coming down in price, and will be more attainable. And actually be more invisible in the background, rather than us having sort of smart hoops or Fitbits or watches, where they will track our every parts of our life, because of, as we know, you know, mood and sleep and stress all has an important part of, you know, how we consume and how we move.
Great, thanks, Simon. I think we're coming to a sort of natural conclusion in a discussion that's covered a wide range of areas. Just before I ask for some final thoughts from our panelists, is there anything that we haven't covered that anybody has the burning need to pick up on? Neel?
Yeah, I mean, because we, you know, there's a bit of an elephant in the room that we haven't really got into, which is the weight loss medication. So that is clearly a big innovation. You know, for years we've been looking for medicines that work, help people lose weight, and are safe broadly, and we have those now. So we're getting really, we've seen really significant results, almost getting close to bariatric surgery level. So there's a big question of, well, does all the stuff we've just talked about, behavior change theory, and all, is that obsolete now? And I think, you know, for me, it's the exact opposite. I think now more than ever, all of that stuff is incredibly important. The weight loss medications alone will not achieve anything. People will not stay on them, and you know, for long enough for them to have an effect. And it will stop them without all of that support. They'll end up less healthy than when they started. So actually, all the stuff that we've talked about is an adjunct to the weight loss medication, and is actually essential. So the two do work synergistically, because I think there's this misconception that all of the stuff we've talked about in terms of behavior change theory and the importance of diet and prevention goes out of the window now. That absolutely isn't the case. I think it's more important than ever.
Yeah, thanks for bringing that up, Neel. Simon, I think you wanted to come in.
Just to pick up, I mean, the service Oviva provide in the UK is unique. I mean, it's phenomenal to be able to provide and prescribe that behavioural change program for those 2 years. For me, producing these drugs, and obviously we've got the likes of Novo and Lilly at the forefront at the moment, but there are a long list of them coming on the way. Government should be looking at those pharmaceutical companies and making sure that there are adjacent behavioral change programs, because being on the drug is one thing, but the last thing we want to see is yo-yo effect, and we need them to be on the drug long enough that their behaviors change, but that behavior change becomes the normality. It's not something to go, oh, I can't wait to go back to my normal ways. It's to basically say, hey, listen, I'm living my new lifestyle. Look at me. I'm looking fantastic. I'm getting these compliments. I like photographs being taken of me. I want to be doing things with my kids because I'm sort of slimmer and healthier, and I want to do things. So I think from a state point of view, worldwide, we should be looking at those pharma companies to basically say, where is that behavioral change element? And it might be teaming up with the likes of Oviva, with likes of Yazen, with the likes of Sweatcoin and others, to basically say, okay, in different regions, can you help us provide that longer term behavioral change, which will enable them to get a license for the drug, maybe allow them to provide a patent for a little bit longer, or a post-patent strategy where actually we're the only provider that provides the long-term education and care for the patient.
Thanks, Simon. So some final words from our panelists. I'm going to start with you, Martin. Legislators possibly listening, decision makers, if there were one or two big things that you think promise even more improvement and change for the future, what do you think they are? The one or two things that you'd really like to see move forward to improve that pattern of weight loss and battling obesity?
Thank you, Alistair, and thank you for having me here. I think addressing that question about the future, we all know that there are many drugs that now have proven to be very effective, and there are coming even more drugs that will be even more effective. But these medicines are not miracle cures alone. Many patients, they experience them as such, but they must be combined with lifestyle support that Neel and Simon mentioned. And the treatment is still complex, but these new drugs combined with digital technology and lifestyle, it's really a paradigm shift, I think, for obesity treatment. And there are now completely new possibilities for effective treatment of obesity. And I will say that obesity, it costs society enormous resources, but also increases the burden on healthcare and crowds out other patients who would receive better care if there were fewer patients living with obesity. So I think that the drugs, they must be cheaper also and available for more patients. It's what I want to see in the near future. But I am happy to say that there is a new hope for anyone living with obesity now, really. So the future is bright, I would say.
Brilliant. That's a really positive note to conclude your contribution, Martin. Thank you. Same question to you, Neel.
Yeah, I suppose a few of the things we've touched on today, really, so the education piece, getting everyone to that shared understanding that obesity is not a lifestyle choice, it's a chronic, complex condition with lots of implications for the individual and for the health service and society. One of the things I talk about a lot is we need to do prevention and treatment well, both of them. They're not mutually exclusive, so we need to focus on both of those sides. And I think there is, as I said earlier, the scope for so much innovation on both elements. Relatively, putting aside the need for policy interventions on the prevention side, but there's so much scope for relatively low-cost, population-level digital interventions on the prevention side that can, as Simon and his colleagues at Sweatcoin are doing, can reach so many people. And that's the sort of scale we need because of the scale of the challenge. There's the sort of more intense, slightly more expensive treatment side. But when you compare that to the cost of delivering traditional face-to-face healthcare services, it's still very good value. And it allows us, again, to scale, to deliver to the numbers of people that need our intervention on the treatment side. So, 25% of the adult population in the UK living with obesity. We can't have a hospital-based clinic model. We don't have the workforce. We don't have the space. We don't have any of that. It just isn't fit for purpose. So we have to scale using digital, and then we can reach the right people as well, the people who won't ever attend a face-to-face clinic appointment. So I think it's thinking about both sides of that equation, the prevention and the treatment side, giving them equal attention and innovating on both sides.
Great, thanks, Neil. And Simon, you get the final word.
Thanks, Alistair, and echo the words. Thank you very much for allowing me to be part of this panel. So, listen, Sweatcoin is probably at the base in terms of the starting ladder of getting people to move more. Obviously, the free app is about movement. It's not necessarily more than that. But when we're looking about preventing and educating an audience, here's something for you from an NHS perspective. We have all these different chronic teams. I would like to see those chronic condition teams pooling. I'd like them to come together as a long-term chronic condition team that actually share best practices and formulas, and to maybe rid some of the issues where they have staffing problems or sickness problems in particular teams, and therefore services don't go ahead, which we're seeing within the NHS all the time. So in other words, when preventing and treating and looking at those behavioral change, we've got the obesity, we've got the CVD, we've got the type 2 diabetes teams working together and actually sharing the best possible resources, and whether that is a face-to-face program, a hybrid program, or a digital program, which there's no doubt about it will definitely be the long-term future. In fact, ourselves, we're looking at a self-fulfilled digital version of our program, because we know there are going to be people that prefer that going forward.
Thank you, Simon. And on behalf of Health Tech World, I'd just like to thank our panelists for what has been, I think, a fascinating and incredibly positive discussion. So thanks very much for sharing your experience and your insight and your hopes for the future as well. The discussion today will be edited and the video will be uploaded on YouTube a little later this week. It'll also be embedded in the Health Tech World blog, and we'll be sharing it on social channels. So for everybody watching, thanks for giving up your time to watch. I know our panelists will share this. Please, for everybody watching, share it far and wide. I think this discussion deserves to be and should be seen by as many people as possible. So thanks once again for watching, and a big thank you to our panelists for a great discussion. Thank you.
Thank you.
Thank you.